Good morning, everyone. Welcome to HealthRecon Connect's webinar on COVID Rollercoaster, What's Next? I am Mitch Green, VP of Sales. This morning, you will be learning about infectious disease, MolDX, Z codes and TA primer, COVID reboot reminders, NGS rethink. To walk you through these, it is our honor to introduce you to Director of Laboratory Services Support at HealthRecon Connect, Mr. William Baus. William has over 15 years experience in healthcare revenue cycle management. His last decade has been entirely focused on laboratory revenue management, building onshore, offshore, and hybrid teams to satisfy the needs of his clients. William has worked inside laboratories as the internal revenue cycle director with purview over every step in the revenue cycle process, as well as managing RCM vendors. William is tirelessly focused on compliantly maximizing the revenue for laboratories, whether that is through the adoption of technology, application of deep state knowledge of payer and national coding policies, or providing access to relationships that can change the bottom line for labs. A few reminders to everyone. If you would like to ask a question, please you may do so by sharing your question in the chat box or by raising your hand, and one of us will enable your audio. Following the conclusion of the webinar, please take a few minutes to fill out our short survey and let us know what you liked about the webinar, how we can improve, and other topics that you would be interested in coming back and listening to more webinars. As a reminder, the recording of the webinar will be published on social media, and we will send you a link through email. Please feel free to share this with your colleagues who couldn't make it today, and with those who may find the content covered useful. With that being said, it's time to get the show on the road, and I will turn it over to William.
Thanks, Mitch. Thank you, everybody, for joining. And do please raise your hand and put in chats. Mitch will pay attention and remind me if there's a question that might be appropriate for a particular section that we're in on the discussion. But very excited to have you guys here with us today. And yep, so what's happening with this COVID roller coaster ride? So that's the agenda. We're going to go over these topics.
William, could you please share your screen?
Oh. My bad. Is it?
Very good, thank you.
It's not putting a box around it, but you're seeing the thing that says notice now?
Yes.
Okay. Good. All right. Let me know if it goes away. So our agenda, as already stated, we're going to go over what's happening with the infectious disease, the Z codes, and the TA primer, the COVID reboot reminders, and some questions about NGS that keep popping up again. So a lot of this information we're going to talk about can be confusing. Depending on what MAC you're in, there can be differences about whether a certain thing applies to you or doesn't apply to you. So we take no responsibility for you taking any of the information that we provide here today and it resulting in a loss of income or clawbacks or anything like that until we actually talk with you specifically about your situation. Please let us help you with it. But we're going to go over a bunch of topics today. So please feel free to ask questions, and then maybe we can even set up a private session to review things with you. Okay, so infectious disease, MolDX back and forth. This has continued to happen, but let's first just do a quick description. So a MAC is a Medicare Administrative Contractor. And as you can see, these are private companies that are awarded geographic jurisdiction for the processing of Medicare claims on the CMS's behalf, right? So the MolDX MACs are MACs that utilize the MolDX program. The MolDX program was originally created by McKesson in 2011. It was subsequently purchased by Palmetto, who owns the MolDX program and who also owns the DEX Exchange, where it's the online database where you actually go and register for your Z codes. And then that database is accessed by any MAC that utilizes the MolDX program. So there are 3 MACs that don't use the MolDX program, and they have LCDs and billing and coding articles that might contradict or be very different than what you'll deal with as a MolDX MAC with a Z code. Those MACs would be Novitas over here, which is Texas and the contiguous states, Colorado, First Coast, and then you've got NGS, not to be confused with next generation sequencing, but rather National Government Services over here on this side of to the west of the Great Lakes, and then north of New York and above. And so the only MACs that are impacted by the molecular syndromic infectious disease panel LCDs are going to be the MACs that are the MolDX MACs: Palmetto, Noridian, WPS, and CGS. All right, now that being said, there's been a lot of updates, and if we have a chance to, after we get through with everything else, I'll go over some of the last changes that have just started occurring in the past couple of days. But for the most part, this is where we're at. Palmetto just implemented as of yesterday their billing and coding article and their LCD. And as of last week, there were some massive changes to it that I think we should discuss if we have time. WPS is still saying 417. I assume that it's going to be more like in line with Palmetto, but maybe not. CGS and Noridian, it actually is implemented on 7/16 for dates of service on or after that, but keep paying attention to that. Revision effective dates, you have to be careful with understanding how those work, and if I have a chance to pull that up, we'll go into that. And of course, the date of service for your claim is the date that the sample was collected. All right, so this is one of the biggest changes as well. So it's always said in the article that if you're FDA approved / cleared and you use the diagnostic codes and the CPT codes in the billing and coding article, then you don't need a Z code. But this would only work for tests that are FDA approved and cleared, of which there are FDA approved and cleared tests for respiratory pathogen panel, the GI panel, the meningioencephalitis panel, some UG-AG panels, and yeah, that's it, right? Yeah, I think that's about it. So that means that for nail or wound or UTI or ophthalmology, those panels do not have FDA approval or clearance. And so for sure you have to have a Z code. And this is also reiterated because if you don't have a CPT code in a group, and there are 7 groups of CPT codes in almost all the LCDs, Palmetto just recently added an 8th group to tell you what CPT codes they are not going to pay for. But there's rules about that as well. But taking into consideration, understanding that you don't have a diagnostic code group going with a CPT group in the billing and coding article, then you know you need a Z code for that test, right? That's the easiest way to look at it. And of course, if you're going to say that your test is FDA approved, you better have a 510K that says your test is FDA approved, right? I think the important thing also to note at this point of thinking about this is, you know, it's going to be difficult for Medicare, who is a good faith payer, to determine when you submit a claim that you're actually using an FDA approved test. And this is because there's nowhere to put on your claim form that your test is FDA approved, unless your FDA approved test is using a PLA code, and that is unique to that FDA approved test, which they would then know, right? But some people are going to have FDA approved tests that don't have their own PLA code. And so Medicare is going to be a good faith payer and pay you for a while until they ask you for, hey, show me that 510K. And then if you don't have it, they're going to want that money back. All right. So let's move on to what is the MolDX program? What's a Z code? What's the diagnostics exchange? And how do I get a Z code? And what's a technical assessment? So in general, the Molecular Diagnostic Services Program, shorthand for that is the MolDX program. As I think I mentioned already, you know, it's originally done by McKesson, is owned by Palmetto. If you are a MAC that participates in the MolDX program, what that means is you're probably paying money to Palmetto, and Palmetto is helping you as a MAC, figure out what you're going to pay for or not. And what they're going to do is they're going to look for, when you're billing an infectious disease panel, they're going to go and look to see if you have a Z code on the DEX exchange, the Diagnostics exchange, which is an online database where you put in your Z codes. How do I go about getting a Z code? Well, I'm going to actually show you a very quick. This is utilized, if you read through the FAQs on the DEX exchange on how to go about filling out a Z code, one of the things they'll mention to you is the add lab test worksheet, and you should run through this worksheet, record your answers before you log in and try to do all of that. And as you can see, there are 36 steps here that you go through to get a Z code. A lot of it is going to be related to some administrative things, like what do you call your test and what's the title. This is an important note here as well. If you're not running the test, right, you need to use the Z code of who runs the test, because the Z code is not a CPT code. It does not replace a CPT code. It provides additional information, as we will see, so that Medicare actually knows what it's paying for when it pays for it. And those being the Medicare MACs that utilize the MolDX program that look up your Z code, now they understand exactly what you did when you ran that test and we use a particular CPT code. And so one of the things is, are you the performing lab or not? If you're not the performing lab for the test you're trying to get a Z code for, then you don't need one. What you do is you register on the Diagnostic exchange and you go to the lab's link inside that database and request the Z code for the test that they're going to be running for you, so that when you bill it, you get the Z code. When you get that Z code, they should also tell you what the CPT code is that goes with that Z code, and you would know then what you're going to be paid, because the CPT code is still going to always be the same fee schedule. Just another little point here. This is what the clinical laboratory fee schedule looks like. You can look at a particular CPT code and you can see what the Medicare fee schedule is. What you'll notice about this is, wherever you are, in whatever state you are, whatever MAC you are, the CPT code that you are given or the CPT code that you use will always be the same price. How you get paid more or less for a particular panel is about a combination of whether or not you get paid for a specific CPT code or not at all. So it's not like you get paid more money for a CPT code. Unless, of course, we're talking about unlisted codes. That's a more advanced topic, but there's only a very few of those. And I will touch on that anyways. So if you're not the performing lab for the test that you're trying to get a Z code for, stop and go get the Z code from the lab that is actually performing the test. And as you can see, the Z code is peculiar to the lab that is running that test. And is this test intended for Medicare beneficiary? So, there are actually a few other payers, two blue states, I believe, and United Healthcare for the Medicare Advantage is listed as that. And pretty much anybody that you're billing under a Medicare Advantage, you can expect that you're going to need your Z codes for that as well. But for the most part, it is a Medicare specific only requirement. So, your answer, that's going to be yes or no. You describe your test. Here we start getting into the clinical relevance of these things and what you need to do to put this information in. And you can see, what is the list of pathogens we're going after? Are we looking at any variations, mutations, maybe possibly for your microbial resistance? You would have something there. Mutation would probably be more appropriate for hereditary cancer or somatic cancer testing. If your test happens to be FDA approved, and in general, if you read the DEX exchange, you are even if you have an FDA approved test, you are supposed to get a Z code. Although we did have an out in most of our LCDs that indicated, well, if your test is FDA approved and you use the diagnostic code and the CPT code, and there's some more that we'll get into later, well, then you could use that. But there seems to have been a little backtracking, and if we have time today, I'll try to show you some of the newest updates that just happened in the past couple of days. But if you've got FDA approval and you go through all of this purple stuff and put that in, now the real meat of the Z code begins to happen here. So a test type would be a drop down, the diseases and disorders will be a drop down, but I do think it makes sense to have a clinical person helping you walk through this concept, what your methodology was, what medical specialties, again, a little question of the FDA. Now, here's where your billing entity comes into its own with helping you on a Z code. We're going to put down the CPT codes that we would like to bill in relationship to your panel. As there have been a lot of changes in how they think of what CPT codes are payable, even listing out a bunch of CPT codes in Group 8 now under the Palmetto LCD of what they won't pay for under very certain conditions. It is unlikely that the way a UTI would have been coded in the past will be the same CPT codes they allow you to use once you get your Z code. But anyways, your billing company is going to say, hey, here's what we want. And then after you get your Z code, they're going to say, yeah, but here's what we're going to let you use. And then we get into the advanced sections, some of which are addressed in the technical assessment, which also must be completed for the infectious disease pathogen panels that you're going to be doing. So it's a two-step process. Number one, fill all this stuff out, these 36 steps for the Z code. Once you get your Z code back, then you can turn in your technical assessment. I'll do a little quick show of what that looks like. But as you can see, if you're using an algorithm, they're going to want to know that. If there's comparable tests, it's optional. Specimen information handling instructions, estimated turnaround time, all of these optional, but right when we start hitting clinical validity, precision, sensitivity, specificity, the predictive values, negative and positive, those are components of the technical assessment. And so what you would probably want to do is do your best about filling this stuff out, leave what's optional out of it, begin working on your TA so you can get your response back on your Z code. When you do your technical assessment, when you do your technical assessment, you can see you've got a couple of pages worth of information, but the first thing that you have to be able to turn in your technical assessment is going to be the Z code they gave you. So you can't turn in your TA until you've done your Z code, but that doesn't mean you can't be working on it in parallel to working on the Z code, or while you're waiting around for your Z code, you could be working on filling out this information. There are 4 tabs. It's interesting to me, as of I downloaded the original one on 4.6. It only had 2 tabs. I downloaded it again yesterday and we had 4 tabs now. So things are evolving as this goes through. Nobody's going to know everything that works for your particular Mac right out the gate. There are slight variations, but for the most part, everything should be the same. And as far as the Z code goes, they're also modifying what they're doing as they go through this, and I'm sure there's being lots of submissions, so they're trying to be more specific. So the longer you wait around to do this, the more detail you're probably going to have to incorporate before you can get your Z code. And as you can see, negative samples, positive samples, again, you need your Z code identifier. Then you got sample level data they want. And here's where I think the rubber really hits the road and wasn't quite as detailed. It's more detailed now than it was before. You've got these 3 concepts. You've got analytical validity, you've got clinical validity, and the most important one being clinical utility. If there was one thing that I would communicate to any laboratory is, well, no, you're not necessarily clinicians, and the medical necessity is dictated by the ordering provider. That is true. But what is also true is the lab is the one that is getting paid. And if there is a question of medical necessity, and there is a lack of it, medical necessity, including clinical utility, and clinical utility here meaning that the test is actually utilized and can be utilized to change the treatment of a patient, which is very important when you consider the pathogens that you're testing for the type of patient that you're testing, whether or not it's considered necessary, medically necessary with clinical utility, the way Medicare thinks of that, right? Which is not necessarily the same thing as saying what is medically necessary from a clinician's perspective, i.e., Medicare basically thinks there's only 2 things worth knowing in a inpatient setting in a non-immunocompromised patient. That is to know whether it is COVID or whether it is influenza, because there are treatments for both of those. Every other viral pathogen that they're going to find, your response to that in a non-immunocompromised patient, according to Medicare, and this is in the LCDs, you can read, they don't really think it's medically necessary. Don't believe there's any clinical utility to finding that information out. So be very specific about your clinical utility section in this technical assessment. That is going to be what makes sure that you get paid and reimbursed for all of the pathogens that we're going to want to put codes down for. Okay, so let's move on. So COVID reboot reminders. So it's just a reminder of us having all of the same information that we always needed, right? Well, I guess we can't say always needed. At the very, very beginning of the pandemic, Medicare came out and said, no, you don't need a provider order for COVID test. And then a couple months later, they literally came back and said, yeah, I know we said you didn't need, a physician order, but now we're saying you do. And the way their rationale was, well, if you're getting tested multiple times for COVID, there must be something going on. So surely you should take the time to have a physician take a look at you, because maybe something else is going on, right? Now, of course, I'm talking about PCR COVID testing, right? Not the free over-the-counter lateral flow devices, right? Diagnostic codes, symptomatic or asymptomatic. And they don't like screening, unless, of course, we're talking about California with Senate Bill 510, then whatever reason, for any reason, for no reason at all, they've got to cover you, but that would only be on insurance that California has jurisdiction over. But then let me show you really quickly things to think about. Diagnostic testing is considered diagnostic testing because it is relative to the condition of the patient. So then by default, if there's no condition of the patient being symptomatic, or we have a couple of non-symptomatic diagnostic codes as well, like the Z20.822, this is expected exposure, even though I would be asymptomatic. It's still related to me because I was exposed to somebody with COVID, and that is supposed to be for greater than 15 minutes within 6 feet, according to the CDC. I have not yet found a better definition, or I have not noticed that Medicare or commercial payers have really defined that. So if there was a definition, I would go with the CDC recommendation for that. I'll skip over the HRSA since it doesn't matter right now. I'm hearing good scuttlebutt that they're supposed to be restarting that program with new funding, but so far that has not happened to my awareness. Now, these kinds of CPT codes are here, and this is very important. Non-diagnostic testing is this kind of testing: return to work, return to school, travel, entertainment, these kinds of reasons for testing. The reason they're not considered diagnostic testing is because it's not related to the condition of the patient. It is rather a condition of the, let's call it, facility for access to its services or its premises, right? Which then by very definition is not diagnostic. It is related to an organizational requirement, right? That doesn't mean you can't have both of these things happening at the same time, but you want to be recording symptoms or suspected exposure from somebody and using those appropriate diagnostic codes so the payers then pay you properly. So if you're having problems getting paid, you're probably using a Z1152 or a Z1159, which is kind of funny because, Z1152, Medicare is saying it's not appropriate to use during a pandemic, but when else would you use that code, right? So go figure, right? What we want are symptomatic diagnostic codes and or suspected exposure, particularly if we're going to be billing commercial payers who will be looking very closely, more closely than they have in the past, at the CARES Act. And the CARES Act does only require them to cover diagnostic testing, right? Okay. So let's go back to, so yeah, on 714, we should see whether or not the pandemic is going to be considered as continuing or not. The CARES Act does stipulate that cost sharing should be waived until the pandemic is deemed over. But we're getting down to the last couple of re-ups here probably. And there's very important considerations for the syndromic panels, which I'm going to revert back to in terms of whether or not you're going to get paid for a one pathogen panel, because they actually do mention that that's not medically necessary in these LCDs. So that could cause you problems getting paid for COVID. But I think I have good news. Major payers honor waive cost share through the PID. Yeah, so the major payers are still indicating in their documentation as of last week, when I checked through these major payers again, they are still stating it's going to be good through the end of the pandemic. And that would be not only for diagnostic testing, but in many instances also for an office visit for a patient that results in the order of a COVID test. That'll be also said, and that's kind of important to you as a lab, because the people that are going to be going out there and collecting samples can still be paid for the collection of that sample. And I'll kind of talk about that with a little diagram in a minute. So your collection codes. Okay, so G2023 was meant to be billed by a lab, that is true. And it was meant for lab personnel to be collecting a sample. That is also true. What was missed, I think, in many instances is that it was also meant to be collected on behalf of a home health agency for a homebound patient, which is probably not the case at a tent, right? Or even somebody coming to your lab unless you recorded that information. It's certainly not going to be everybody. And then of course, G2024 is if you were a lab and you were going out to a skilled nursing facility, you got paid your extra $2, right? So if you were going out to assisted living facilities, helping homebound people get their samples collected, that would have been your G2023, not at a tent. G2024 would have been if you did that at a SNF, and a SNF always gets $2 more for this kind of stuff because of some Social Security Title Act that was enacted many years ago. And that's why you'll notice there's a $2 difference there. Okay, HRSA is done, but what can you do? So if you've still got people that you had submitted to HRSA, or you would have submitted to HRSA because you didn't have insurance information, you might potentially want to perform an insurance discovery to find out maybe they did have insurance, and then go ahead and bill their insurance. There's a couple of caveats to that, and you would want to talk to us to make sure that, well, you had documentation that maybe the patient signed that would give you the authority to do that, but we would want to look at your documentation. COVID genotyping. Okay, so a lot of people were asking, can I get paid for variant testing? I think there were a couple of risky methods that would be highly suspect of, like billing it again, billing your COVID code again, maybe for looking for a variant. There's really no support for that. In fact, many of the codes we use, depending on, there's a couple of different COVID codes you can be using, right? But many of the COVID codes indicate that it is for the subvariants as well, right? So probably not a good idea to do that. They have released a code 87913, which is exactly that, genotyping, figuring out the variants for the COVID virus, but there is no fee schedule. And as near as I can tell, the only documentation I've found says that we're probably going to get a fee schedule for that in 2023. And so that's COVID reboot reminders, something to think about there. Let me get past these. And I wanted to make a few comments about, the org structure. Well, let's go ahead and do Senate Bill 510 first, though. Well, if you're taking samples from California and people have California insurance, well, that's good news for you because, for whatever reason, for no reason, for any reason, California said you got to cover these COVID tests. They have to be EUA or FDA approved, of which I don't believe there are any FDA approved COVID tests, but that could change at any time. It would be the plans that California has jurisdiction over, works for in-network or out-of-network. It is for testing, but as I mentioned earlier about, visits related to COVID testing would also be covered as well. The rates that they're supposed to set are reasonable and necessary market rates. So far, I haven't really seen anybody try to dip below the Medicare allowable in general. I mean, there are some HMOs and some MCOs that try to play that game. But for the most part, your commercials are going to do Medicare, even though they really should have done your posted rate, because that's actually what's written into the CARES Act, that your posted rate, unless they negotiated with you, is what they were supposed to pay you, assuming that that was your true posted cash rate and you weren't messing around. You might have been able to make, $200 instead of $100 on certain plans that would have obeyed that, right? No balance billing, of course. And it was retroactive too. So that's another thing to think about with all this. If there's any claims that you haven't gotten paid for because you used a screening code, for example, and that's kind of a thing that goes on. A lot of people aren't paying attention to the diagnostic codes they're using, and you're not getting paid because they don't have to pay you for screening under the CARES Act. But this is Senate Bill 510. And in California, they said for any reason. So if you didn't get paid for any reason for any COVID testing in California, you should probably go back and bill that stuff again. And this Senate Bill 510 will be in effect for as long as the governor of California says that there is still a pandemic happening. All right. Now, there were these different organizational structures which still seem to be occurring. And I think what anybody should look at by now is if you're a lab that's being approached by a group wanting to do COVID testing, I would do my due diligence because you want to make sure, well, there's probably a reason why they're wanting to work with you and not a lab that they probably were working with in the past, right? So you want to make sure you do your due diligence and make sure a few of these things are happening. Now, if you want to be a lab that goes out and sets up locations to collect that, then yes, you can do that, but you still need a signed physician order. And there's some complexity around that. I mean, you could even have a nurse practitioner who's billing incident to a physician that would allow you to have her signing off or him signing off on orders. And you would want your CLIA updated with mobile locations. You would, you do not want to be using the G code for the collection of that sample. So now you've got a problem where you're going to have to pay a physician to collect samples, right? And so there's a lot of details that you would need to work out, and you would definitely want to talk to a lawyer before you set this up on your own, but it can be done. You can set up your own collection locations. Just make sure you get a signed physician order. I'm not a big fan of using the medical director at the lab to sign off on the order, but if you have policies and procedures sufficiently in place, and I am not offering you legal advice, but I think you should get legal advice on this, that there may be a way to achieve that in a legal and compliant manner, right? Okay. The other way is where you're not managing it, and some other collection agency is doing that. And what they're probably doing is, billing for an evaluation and management service, which is, if that's a visit that results in a COVID, then it gets covered under the CARES Act, right? So they should have no deductible or copay going on. Make sure that you're getting diagnostic codes that are not screening for the most part, unless of course you're dealing with California. And don't try to bill insurance for surveillance or screening testing. Return to work, return to school, and all of that. Don't forget the fact that you're going to need licensing, perhaps, whether that also be licensing for processing the samples at your lab from an out-of-state location, but also permits and things that you need to have where you're setting up these locations, right? Yep, and that's generally it, right? The concept as well for the physician that you would probably be working with is they'll probably be billing for not only the E&M service, but also the lateral flow rapid antigen kit. And I think you should highly review that as well, because, the CDC is perfectly fine with a negative lateral flow device, then assuming there are symptoms with the patient, that then doing a PCR test is okay. But the CDC was pretty clear that, well, if you test positive for the rapid antigen lateral flow device, there's really no reason for you to go and get a PCR test. Treat the patient as positive for COVID then. So I would really kind of pay attention to that. I think the further we get into this, the more likely it is people are going to start to pay attention to that. Basically double testing people, right? And then variant testing. I think we discussed that already. In general, I was trying to put it out there that until you have clinical utility for understanding what the variant is, and that is going to rapidly evolve, and to a degree with the mononuclear antibodies, right? Knowing what variant you had might actually make a change in that. I'm not aware if that's the case, but I can see how that would progress very quickly in the future. And so when there is clinical utility to knowing the variant, I can see payers wanting to pay for that. And the indication that there is an AMA code for this already does give us some indication that there obviously is literature out there indicating that there is clinical utility for it. Now, whether or not Medicare will think there's clinical utility for that or not is another question. Yep, so that's really the thought process. I think it's probably not yet, is what I would say. All right, so then the last big thing that I think is, well, what else can I do besides COVID, right? Well, we've got the infectious disease syndromic panels, right? We've got PGX, and we've done a whole seminar on that, so you're welcome to take a look at that. And then people are taking a look back at the NGS again. They're rethinking NGS, whereas if you talk to somebody a year ago and they could easily see between $4,000 and $8,000 for a particular NGS panel for hereditary cardio genetic disorders, as well as Parkinson's, Alzheimer's, dementia, or diabetes and obesity, sorry. These kind of panels. There is a big lack of guidance on it from a medical standpoint as individual LCDs, although there is a very good strong LCD in the non-MolDX MACs for Novitas and First Coast, for example, pretty much indicating that every CPT code you would have used for cardio is not payable. But in the LCD, they did write out the playbook for what would constitute medical necessity. So they tell you very clearly what that would be. I would highly recommend reviewing that. If you believe that you can support that medical necessity for it, then also understand you're going to get one CPT code. This is why people were doing it in, say, Novitas or First Coast or the NGS MAC, because they weren't required to have a Z code for their molecular diagnostic testing, or they are required to have a Z code. So you would look at people going in Novitas and First Coast because you didn't have that problem, and then people were utilizing multiple CPT codes. Well, in Novitas and First Coast, in the middle of last year, in June or July, we had a molecular pathology billing and coding article that came out. And in that billing and coding article, it was very clear that if you run your genes in parallel, that is at the same time, for the same indication, that means you get one CPT code. They actually write, and forgive me that it's rather small to see there, but they tell you very clearly in the LCD, look, man, we don't really expect you doing this on the regular. You could use a 59 modifier if you ran it serially, meaning the result of one gene dictated whether or not another gene was run, or another test was run. Like, that would be very common to see, well, at least a couple of years ago, it would be, unless you figured out how to do this together at the same time. But you wouldn't run deletion duplication on everything normally. You would run deletion duplication when you found a particular mutation, and then, so that means it triggered the running of another test. So that is what it means to run something in serial. If you're not doing that, and you're running everything together, and the genes that you're looking at are all for the same indication, like Parkinson's, Alzheimer's, dementia, right? Well, then you're still only supposed to get one code. So they figured out a way to make it so you only use one code, just like a MolDX MAC would do with a Z code. Only now you don't have to go through the Z code process. And the problem, again, being that many of these codes are going to be sub $1,000. So, if you want to work with a client that, or with a billing entity like HealthRecon, we can help look at your panels. We can explain to you how it would be coded properly. We won't be able to make comments on medical necessity, but we would be able to point you to basically the playbook for that and incorporate clinicians. Then we can take a look at this. But I think the immunology panel that everybody's running around with right now, it is going to get paid, and it's going to get paid because Medicare is a good faith payer. That means they expect us to understand these rules. And so if we don't understand these rules and we don't apply these rules, Medicare doesn't know that. We don't know that. And so we build a claim out, we build it with multiple codes. And since they don't know what they're paying for, they're going to pay it. But then they're going to come back and they're going to be looking for somebody to hang, right? That could be up to and including jail time, right? I mean, federally speaking, it's a big deal for them, right? So if they know that you're willfully trying to game the system, even after they've told you very clearly, don't do it, and you still do it, you're not going to have a lot of legs to stand on. All right, so enough of my soapbox for that.
William,
so
you have
again,
a question in the Q&A.
Oh, excellent. Yay. Let's see, what do we have here? Okay, so what would you recommend CPT code wise for panels like UTI that do not have a dedicated panel code? Okay, it's a very good question. So first of all, if you're in a MolDX MAC, you're going to need a Z code to bill a UTI. There is no FDA approved UTI, or at least Medicare believes that, and they wrote that down in their LCDs. So up until this morning, when I looked at the Palmetto LCD, which is now added Group 8, which was what was notably missing to me in the entire billing and coding article, was all of my individual pathogen codes are gone. So I think what's probably going to happen to us on a UTI is we're either going to get an 87999, which is going to be an unlisted code, which means we'll have to do a gap fill, and the gap fill will be a crosswalk from the CPT codes you would have billed. Yeah, I think that's probably the most likely what's going to happen. Or worst case scenario, they're going to give me an 87801 for $70, right? And Medicare is not using 87801 the way the AMA does. 87801 was intended for a group of pathogens that you didn't differentiate in terms of the result. Like, let's say I did the 5 different kinds of Candida, and I result out that yes, you have Candida, but I don't tell you which one. That's what 87801 was used for. It has an MUE of 3, which means if you did 3 kinds of tests like that, I would have billed that 3 times. And then for specific pathogens that I was explicitly resulting out, I would have billed that explicit code, or I would have used an unlisted, unclassified code 87798. Well, assuming that we're talking about amplified probe, you also need to know whether you're quantifying direct probe or amplified probe to make sure you're doing the right choice on those codes. But for the most part, people are using an amplified probe. So you would have been looking at in, say, the Novitas region for, if you had 13 pathogens of 87798, and then plus you had another 10 or so pathogens of that, you're looking at, a $700, $800 type panel. First Coast is only paying for 2 units of 87798, which is also interesting to me that kind of fits in line with the $70 that you would get paid for 87801. But they do appear to be paying for the individual pathogens. So I think what's going to happen is we're probably going to get some form of an unlisted code or a code without a fee schedule like 87999, which doesn't seem appropriate to me to use because that is a microbiology code, not a molecular pathology code, right? But that's what you can see Medicare telling us to use in the LCD. And so if that's the way they want to use the code, that's the way they want to use the code. I think, do we have any other questions? Because I was going to try to show.
It doesn't look like right now, William.
Okay, so let me do one more thing and let everybody, can you guys see this billing and coding article?
Yes.
All right, so this is for Palmetto. No, that's not for Palmetto. I wanted to show the Palmetto one. Where's my Palmetto? All right, so that's still Meridian. Well, I did want to tell everybody this too. There's lots of differences right now in these LCDs. So there's always the LCD that's going to be, molecular syndromic panels for infectious disease.
pathogen identification testing, right? There's going to be an LCD, there's going to be a billing and coding article, and then there's going to be a response to comments. Okay. Now, not all of the MACs are doing the same things, and they're making some slight modifications all throughout it, right? And so, for example, this is the Noridian one, their revision date 7/16. Their revision is that they're not going to implement this. That means the notice period has been extended to 7/15 because they had to retire a few other policies. Now, Palmetto never went out and said this. They went ahead and did those kind of changes, and they made updates to their LCD up until yesterday, which then it became effective as of yesterday. And so one of the key changes here is you're going to see, oh, this is the LCD. Let me go to the billing and coding article. In their billing and coding article for Palmetto, there are 8 groups. So there's group 1, and it's missing 87801, right? But in Palmetto, it's there. And I assume that these guys are going to update too, because Palmetto's the one running the show, right? 3, 4, 5, 6, 7, and that's it. So we got 7 groups, right? Now, if I go to Palmetto's, maybe this is Palmetto's. Nope, that's Noridian. Oh, the Meridian's open. Nope. Ah, here it is. I knew I had it open. I was just looking at it today. There's 2 really big important things to pay attention to, because one of the things that should have come out clear that everybody should have been asking about is, you know, this LCD for all these people says, sorry, I'm trying to turn that off. What was I going to say? The LCD says, hey, panels of less than 2 pathogens are not medically necessary. So that should have scared everybody about, well, what are they going to do about COVID? Then look, see here are my COVID codes, right? Well, the U codes, right? And then I think the 8763 is 5 is probably up higher up here. But a lot of times, if you're doing a high throughput method, you're going to be doing one of these down here, right? And so this is group 8. And look what they say here in Palmetto, man. They didn't say this until just a day or 2 ago. The following CPT codes are not covered. But don't get too excited. But these codes are not covered when greater than 1 is billed in combination with one of the groups 1 to 7. So what they're telling you is, I'm not going to pay you for a bunch of add-on codes. So if you take that in the context of UTI, you know, I'm going to need a Z code anyways, and so maybe they're going to let me use a bunch of these individual codes. I'm hoping that's what it is. And then they're just going to hassle us on how many of the individual codes we're going to use, right? But, you know, what they're clearly telling you is, if I use more than one of these with one of the ones from group 1 or 7, then I'm kind of screwed. But that's all right, because here's what we could do. You're going to have 2 choices, right? You could say, and I think this would probably be the better choice. You could say, hey, I want to do, you know, one of these recipe pathogen panels, and then maybe I've got some other what do you call them? Bacterial pathogens. I could use an 87801, right? Now we really need to look at your actual panel and what you're doing, or whether we should do that, or whether it makes more sense to try to build one of these codes that they told us they're not going to pay for if you use more than one. But you know, we could run through all of that when we look at your panels. And I think the biggest thing to note as well is the tests that are FDA approved and performed consistent with their intended use do not require a Z code when billed with the appropriate ICD-10. So that's what they've always been saying, right? Then now they've added this. However,
if the performance of multiple approved molecular infectious disease pathogen tests in the same data service for the same intended use in the patient is considered as one distinct service. As such, you would have to use 87999. Which isn't even the right grouping of code for the testing that we're doing, but fine, that's they want to do that. But I think what they're saying here is it's probably going to be better for you to get a Z code. You're probably going to be able to make a little bit more money if you go through the process of getting a Z code. And you certainly want to work with a group that's going to pay attention to your panels, pay attention to your ordering constituency, and really try to work with you to make sure you get the most out of your Z code and get the right CPT code for it. And doing an 87999, this is a code that does not have a fee schedule. So now you have to do a gap fill. And the way you do a gap fill is you say, okay, well, this is what I would have billed if I tested it. And then they're going to ask you a bunch of other stuff, like what's your cost, capitalization, and blah, 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 what's your price, what's your discount, and what the commercial payers pay you for it, right? We're going to have to argue about it. But doing that is going to take a lot longer than just, 45 days to get your Z code, which, by the way, some people appear to be getting their Z codes much quicker than 45 days. But I've yet to hear of anybody getting done with their technical assessment, which that may be your sticking point, right? But once your Z code has been created, then you could go, you would, from that date forward, by date of service, you would be able to use it, even though you're not going to be able to use it until you get done with your technical assessment, because I don't think they're giving us the codes until after the technical assessment now. So that's the biggest change that's really happened, is these, the different MACs are going to implement them over different timeframes. They currently say different things. If I was going to try to make a prediction as far as it goes with anybody outside of Palmetto, is I would make the assumption that they're going to follow Palmetto, because Palmetto actually owns the MolDX program to begin with, right? So I think it's a pretty good indication that these changes that we've talked about, with the change in how they're going to look at some of these CPT codes and whether or not you can be FDA approved or not, is a real deal. But another thing that I think you should think of here is this. Additionally, the following CPT codes are not covered for a given beneficiary on the same date of service when greater than 2 are billed for the same intended use. So anything less than 1 is not medically necessary, unless you're talking about COVID, which they're okay with paying for. So we're still going to get paid for COVID. And that was a big problem everybody should have been worried about, but it's been clarified. But if you looked at Noridians right now, you should have that question: am I going to still get paid for COVID or not, right, if I was doing it alone? Because it doesn't say any of this stuff, right? It does say pathogens less than 2 are not considered medically necessary, but now they're not going to pay you for more than 2. And just as an FYI, every single one of these codes is an individual pathogen. And as long as we're talking about amplified probe technique, that's $35.09. So you're talking about $70 basically is what they're willing to pay you for some panels, right? So I think it still makes a whole lot of sense that you should definitely always go out and look for your Z codes, right? So does anybody have any additional questions?
All right, thank you. I think we'll give it just another second here for additional questions.
All right.
But I think, I guess I'll wrap it up, William. Thank you so much for that. We appreciate it. Audience, that brings our webinar to a close today. We would like to take the opportunity to thank you for joining us. Please do take a few minutes to fill out the survey that appears at the end of the webinar. It'll let us know if you like the webinar, how we can improve it, and what other topics that would interest you in for future webinars. Your feedback is extremely important to us. As a reminder, the recording of this webinar will be published on our social media and sent to you through email. Please keep an eye out for that, share the link, send it on to colleagues who may benefit from the information on the webinar today. Finally, if you would like to learn more about anything you heard regarding billing today, please feel free to reach out to us with the information that's provided on the screen. Our team will be happy to assist you. Until we meet again, stay safe and have a great rest of the week. See you at the next webinar. Thank you.